SwayamPrabha. Digital India. Educated India.
Good morning. I am Dr. Kalpana Ramachandran, Professor and Head, Department of Anatomy, Sri Ramachandra Medical College and Research Institute, Chennai, Tamil Nadu. In today's session, we will be discussing about the development of urinary system. We will begin this lecture by looking at the objectives of the class. At the end of the lecture, you should be able to describe the development of kidney, ureter and urinary bladder, and also describe the congenital anomalies of urinary system. We will begin with a clinical case study. A 45-year-old female presented to the OPD with fever and loin pain. The examining surgeon noticed a lower midline mass on the left side of the abdomen, extending cranially up to the umbilicus, across the midline onto the opposite side. A CT abdomen was done which showed left pelvic hydronephrotic kidney, which was secondary to pelvic-ureteric junction obstruction. CT abdomen also showed gross thinning of the renal parenchyma. A renal scan was done for this patient which showed that the kidney was non-functioning. Hence, an elective nephrectomy was done for this patient. We will correlate this clinical case study at the end of this lecture with the development of urinary system. We will revise the relevant gross anatomy of the urinary system for better understanding of the development of urinary system. As you can see from this picture, the kidneys are paired excretory organs which are situated on the posterior abdominal wall and they are present behind the peritoneum. So, the extent of the kidney is from the upper border of 12th thoracic vertebra to the 3rd lumbar vertebra. Ensuing from the kidney will be a pair of ureters which carry urine from the kidney to the urinary bladder. The ureters also lie behind the peritoneum and they have a course through the posterior abdominal wall and the lateral pelvic wall, and finally they open into the bladder. The urinary bladder lies in the anterior part of the pelvic cavity. We will also revise the relevant development of the embryo during the early weeks before folding of the embryo. If you look at this picture, this is the embryo in the form of a trilaminar germ disc and this is before folding of the embryo. So, the embryo has got 3 germ layers. This is the ectoderm above. In between is the intraembryonic mesoderm and this one will be your endoderm. So, the embryo is in the form of 3-layered disc: ectoderm, mesoderm and endoderm. Amniotic cavity will be present above and yolk sac will be present below. So, if you look at the intraembryonic mesoderm, this is divided into a paraxial mesoderm which later on gets segmented to form somites. Then will be the intermediate mesoderm and lateral plate mesoderm. So, the 3 subdivisions of intraembryonic mesoderm are paraxial, intermediate mesoderm and lateral plate mesoderm. The lateral plate mesoderm shows a cavity which is called as intraembryonic coelom, which in the future will give rise to the pleural, pericardial and peritoneal cavity. Because of the appearance of intraembryonic coelom, The lateral plate mesoderm gets subdivided into two layers. One layer in contact with the ectoderm is called somatopleuric layer of lateral plate mesoderm. So, this what I am pointing out is the somatopleuric layer of lateral plate mesoderm. And this layer which is in contact with the endoderm is called as splanchnopluric layer of lateral plate mesoderm. These are quite relevant to the development of the urinary system, which I will refer at a later stage. We will focus on the intermediate mesoderm in this class, since the intermediate mesoderm is going to give rise to urinary and genital system. So, the urinary and genital system develop from the intermediate mesoderm, as has been pointed out in this picture. So, once the embryo folds, what happens is a portion of the endoderm lined yolk sac is enclosed within the embryo. So, this is the dorsal aspect of the embryo. You can see the amniotic cavity. This yellow colored tube within the embryo, what you are seeing here is the primitive gut tube. So, this is formed because of the cephalocaudal and lateral folding of the embryo. An endoderm lined yolk sac is enclosed within the embryo and we call it as the primitive gut tube. So, this is the cranial end of the embryo and this is the caudal end of the embryo. So, there are three subdivisions for the primitive gut tube, namely this is foregut, this is midgut which is in continuation with the yolk sac, and this one will be the hindgut. Please focus on the hindgut. There is a diverticulum coming from the ventral aspect of the hindgut. You can see a diverticulum in this picture from the ventral aspect of the hindgut. This diverticulum is called as allantois or allantoic diverticulum. What I am pointing out is the allantois or allantoic diverticulum. I will refer this back once we start studying in detail the development of urinary bladder. So, the part of the hindgut, what I am pointing out now, the part of the hindgut distal to the allantoic diverticulum or caudal to the allantoic diverticulum, this what I am pointing out is called as cloaca. This one is cloaca, the part of the hindgut which is caudal to the allantoic diverticulum is called cloaca. So, this cloaca is going to be divided into two parts by a septum which is shown in this picture as a red line, that is called as urorectal septum. So, cloaca is subdivided by a septum which is called urorectal septum into a ventral part and a dorsal part. This ventral part, see in the picture below, is called as primitive urogenital sinus. Primitive urogenital sinus. And the dorsal part is called as primitive rectum. So, most of our focus will be on the primitive urogenital sinus, which we are concerned when we learn about the development of urinary system. So, whatever we have learnt is incorporated in this picture. This is the embryo, head end of the embryo, this is the tail end of the embryo. You can see the gut tube here, primitive gut tube, already showing the three subdivisions, foregut, the midgut loop, and this is the hindgut. And you can see that the hindgut distal to allantoic diverticulum is the cloaca, which is already subdivided here. This is the ventral part and this is the dorsal part. This is primitive rectum and this part is primitive urogenital sinus. Having read this, we will go into the development of urinary system. So, once the embryo folds and the peritoneal cavity is formed within the embryo and the gut tube is suspended by a dorsal mesentery, what happens is there is a ridge which is formed by the intermediate mesoderm within the embryo in the posterior wall. This ridge is called as urogenital ridge. The ridge formed by both systems is called as urogenital ridge. So, we will focus on the urogenital ridge. You can see in this picture the urogenital ridge. So, there are various subdivisions of the urogenital ridge. The medial part of the ridge is the genital ridge and lateral part is called as nephrogenic cord. Lateral part is called as nephrogenic cord, which is going to form the urinary system. So, the medial part is going to form the gonad, male and female gonads, and lateral part is going to be called as nephrogenic cord. This is a section and this is the complete view of the interior of the embryo during development. So, this nephrogenic cord is going to extend from the cervical to the sacral region of the embryo. You see this section, there are some structures formed in relation to the nephrogenic cord. One is the excretory renal tubules. You can see some renal tubules here. These are the excretory renal tubules which are called as pronephros, mesonephros and metanephros. I will be explaining these terms in the next few slides. Lateral to this, there is a duct which is formed which is called as mesonephric duct, and still more lateral to it there is going to be the another duct which is called paramesonephric duct. Medially will be the developing gonads. So, we will orient this to this first picture. So, medially is the gonads, still more lateral to it is the pro, meso and metanephros. Excretory tubules will form in that. Still more lateral to it is the duct which is called as mesonephric duct. Still more lateral to it will be paramesonephric duct, which is not represented in this picture. So, we are focusing on the nephrogenic cord in relation to the development of urinary system. So, as I told earlier, there are going to be three overlapping renal systems are formed in the embryo from cranial to caudal sequence during intrauterine life in humans. They are pronephros, mesonephros and metanephros. You can see them in the pictures which are on the left side. So, we will deal with each one of them separately. So, first is the pronephros. Pronephros is a functioning kidney in some fishes and cyclostomes. In humans, pronephros appear as, see this picture which I am pointing out, structure I am pointing out. Pronephros appear as 7 to 10 solid cell groups in the cervical region of the embryo. This is cervical region of the embryo. You can see some solid cell groups. They form some vestigial excretory units which are called as nephrotomes. So, when the caudal ones start differentiating, the cranial ones will regress. In humans, by end of 4 weeks, this completely disappears. Pronephros completely disappears. So, initial stages in the cervical region, pronephros is formed, completely disappears by the end of 4th week of development. Next is mesonephros. So, from where to where it extends? It is going to extend from the upper thoracic to upper lumbar segments. This is very important. It extends from the upper thoracic to upper lumbar segments when the pronephrosis is regressing. So as we have understood, this pro, meso, metanephros all are derived from the intermediate mesoderm. So mesonephros starts developing. Next, what happens is, like pronephros, here also excretory renal tubules start developing. And what they do is, they are going to open into the duct which is lateral, which is called mesonephric duct. There is another name for this duct which is also called as Wolffian duct. Please note, these mesonephric tubules, the excretory tubules developing in the mesonephros are going to open into the mesonephric duct, which is situated laterally. So this mesonephric duct, we will just see this picture and orient ourselves. The mesonephric duct, I am taking it down, it is going to open into the cloaca. I have already told you what is cloaca. The part of the hindgut distal to the allantoic diverticulum, and we have also seen its subdivision as primitive urogenital sinus ventrally and primitive rectum dorsally. So this mesonephric duct, you can see in this picture also, diagrammatic representation on the right side. The mesonephric duct initially opens into cloaca. After some time, it opens into the primitive urogenital sinus when the cloaca gets subdivided. This is also represented in the left picture. This is again to show the mesonephric duct which is opening into the cloaca, and a picture showing the development of pronephros, mesonephros. We will talk about the development of metanephros. So this mesonephros, by the middle of the second month, it takes the shape of a ovoid ridge. This is a section. As we have told you, this is the dorsal mesentery. Lateral to it, you can see the development of mesonephros. This is in the posterior abdominal wall of the embryo. Medially, gonads are developing. This will be dealt in the next class. So while the caudal mesonephric tubules are developing, the cranial ones start degenerating. So in humans, by the end of second month, most of them have disappeared. So in males alone, some of the caudal tubules and the mesonephric duct will persist and form the genital system. So this disappears in females. Next is the development of metanephros. In humans, it appears in the 5th week of development, and this is the one which is going to form the permanent kidney. So it is metanephros which forms the permanent kidney. So where is it developed? It is developed in the, you can see in this picture, in the lower lumbar and sacral regions, the metanephros is developed. So this metanephros, again like pro-meso, as we have already told, excretory tubules start appearing, just like the mesonephric system. These are the excretory tubules which are developing, which are going to develop into parts of the nephron in humans. So this is the metanephric blastema, which is going to give rise to the nephron, parts of the nephron in humans. I told you this metanephros is forming the permanent kidney in humans. Just look at this picture, get oriented to this. This one is your distal part of the hindgut, distal to the allantois, the cloaca. It is starting to subdivide. You can see that this is primitive urogenital sinus and this is primitive rectum. We have already talked about the mesonephric duct, which is going to come and open into the primitive urogenital sinus. So there are two entities in this picture. One is the mesonephric duct which is opening into the primitive urogenital sinus. Another is the metanephros, which is going to give rise to nephrons. So, at this stage what happens is there is a bud which is arising from the mesonephric duct. From where it is arising? From the mesonephric duct, close to its entrance into cloaca. So, this bud is ureteric bud, also called as mesonephric diverticulum, because it is arising from the mesonephric duct. So, now we will focus on two things. One is the ureteric bud, it is a mesonephric diverticulum. Another one is the metanephric blastema. The fate of these two will be discussed in the next few slides. So, this ureteric bud is growing into the metanephros. This is metanephros. This ureteric bud is growing into the metanephros. It is dilating to form the pelvis of the ureter, or it is called ampulla. This is the pelvis of the ureter, or it is called as ampulla. Further divisions of this ureteric bud gives rise to the major calyces. In this picture, further subdivisions gives rise to minor calyces, and finally the collecting tubules. So, what is shown in yellow color is coming from the ureteric bud, that is the collecting part of the kidney is developed from the ureteric bud. This is coming in contact with the metanephric blastema, which is going to give rise to the parts of the nephron. Again, this is another picture showing the ureteric bud dividing into various generations of branches. So, as you can see from this picture, the collecting tubule is covered by a metanephric tissue cap. So, this metanephric tissue cap is going to give rise to the nephrons, or the excretory units. So, the parts developed from the metanephric tissue cap are Bowman's capsule, PCT, Henle's loop, and the DCT. So, this is a picture to show the various stages in the development of the metanephric blastema. Initially, it is in the form of a cap. This is called as cap stage. Then it becomes a vesicle. Then it becomes comma shaped. Then it becomes S-shaped. And finally, the metanephric blastema differentiates into various parts of nephron, namely Bowman's capsule, then will be the PCT, Henle's loop, and the DCT. So, this picture shows the various stages in the development of nephron. So, to put things together, the excretory units of the kidney develop from the metanephros, namely the Bowman's capsule, the PCT, Henle's loop, and the distal convoluted tubule. This only develops from the metanephros. This is the excretory unit. As I said earlier, the metanephros comes in contact with the ureteric bud. So, the ureteric bud gives rise to the collecting system of the kidney, namely the collecting tubule, the collecting ducts, the calyces, pelvis of the ureter, and the ureter. So, there are two sources of development of kidney, excretory part and the collecting part. Excretory units develop from the metanephros, while the collecting part is going to develop from the ureteric bud. Nephrons continue to form until birth, at which time there are about 1 million in each kidney. So, look at this picture. We said metanephros develops in the lower lumbar and sacral region. So, it is initially formed in the pelvic region. So, the adult position of the kidney is in the lumbar region. So, kidney ascends up
during development. So it shifts more cranially, the reason being one is there is decrease in the body curvature. Two is there is growth of body in the lumbar and sacral regions. And three is there are various pelvic organs being formed at the same time and hence the kidney ascends up to the lumbar region. So initially it is in the pelvic region, later it shifts more cranially. Once it ascends, initially the hilum of the kidney is facing anteriorly. What happens is there is going to be rotation of this hilum and hence this hilum faces medially in adults. From anterior position it moves more medially. So this is rotation of the kidney. So if you look at the functioning of the kidneys become functional by around 12th week of development. So the fetus starts excreting urine into the amniotic fluid. As we understand, the fetus is surrounded by amniotic fluid. So urine is passed into the amniotic fluid. The same thing is swallowed by the fetus and it is again recycled through the kidney. The importance of this is that if there are going to be congenital renal disorders, one, it can be agenesis of the kidney is not formed, or there is obstruction in the collecting system. What happens is the mother will present with oligohydramnios, very little amniotic fluid. This is because kidneys become functional by 12th week and urine is one which is contributing to the amniotic fluid and it's swallowed by the fetus and it is recycled through the kidney. So congenital renal disorders can result in oligohydramnios. This is about the functioning of the kidney. Having read about the development of kidney and ureter, we'll just summarize what we have learned till now. As I said, there are various stages in the formation of the urinary system, namely pronephros, mesonephros and metanephros. It's the metanephros which develops in the 5th week, which forms the permanent kidney, that is the excretory units, namely Bowman's capsule, PCT, Henle's loop and DCT coming from the metanephros. We also talked about a ureteric bud, which is nothing but a mesonephric diverticulum which comes in contact with the metanephros. So once ureteric bud comes in contact with the metanephros, it induces the metanephros to form the excretory units. The ureteric bud itself gives rise to the collecting system of the kidney, that is collecting tubules, the ducts, the calyces, pelvis and the ureter. As has been told earlier, kidney develops in the pelvic region and later on it ascends to the lumbar region. So this summarizes the development of kidney and ureter. Next we will move on to the next part of our lecture, that is on the development of bladder, urinary bladder. We have already reviewed the development of cloaca in our initial slides. So we said cloaca was the distal part of the hindgut which was distal to the allantoic diverticulum. And we mentioned cloaca was subdivided by a urorectal septum into a ventral part which was called as primitive urogenital sinus and a dorsal part which was called as primitive rectum. The primitive rectum gives rise to the rectum and upper part of anal canal. For this lecture, we will focus on the primitive urogenital sinus because of its relevance to the development of urinary bladder. So, this primitive urogenital sinus is again subdivided into a cranial part, what is shown in blue color, and a caudal part. The cranial part is called as vesico-urethral canal. This is vesico-urethral canal. And a caudal part which is called as definitive urogenital sinus. This is definitive urogenital sinus. This caudal part, definitive urogenital sinus, will get subdivided into a pelvic part and a phallic part. So, I repeat again, we are focusing on the primitive urogenital sinus, which is nothing but the ventral subdivision of the cloaca. This primitive urogenital sinus is subdivided into a cranial part which is called as vesico-urethral canal and a caudal part which is called definitive urogenital sinus, which gets subdivided into a pelvic part and a phallic part. So, the urinary bladder develops from the cranial part of the vesico-urethral canal. Please understand that these are all subdivisions of cloaca, and cloaca is the part of the hindgut distal to allantois. So, it is the hindgut, part of the hindgut. Gut tube itself is endodermal in origin, and hence bladder is endodermal in origin. So, urinary bladder as seen from this picture develops from the cranial part of the vesico-urethral canal. It is endodermal in origin. Already we have mentioned that the caudal portion of the mesonephric ducts gets absorbed into, it opens into the primitive urogenital sinus when we talked about the development of the kidney and ureter. Now what happens is, this is the posterior view of the vesico-urethral canal. This cranial part is going to form the bladder. So, this is the posterior wall of the urinary bladder. So, you can see the mesonephric duct opening into it, and from the mesonephric duct there is a ureteric bud which is called as the mesonephric diverticulum. Now, what happens is, this caudal portion of mesonephric duct is absorbed into the vesico-urethral canal. It is absorbed into the vesico-urethral canal. See the difference between this picture and this picture. This portion is absorbed into the vesico-urethral canal. Because of this absorption, what happens is, the ureters, initially an outgrowth from the mesonephric duct, is now opening independently into the posterior wall of the bladder. Because of the ascent of the kidney, what happens is, the orifices of the ureter move cranially, and those of the mesonephric duct move caudally, and they are going to open into the prostatic part of the urethra. It is going to open into the prostatic part of the urethra, and this caudal part of the mesonephric duct is going to form the ejaculatory duct. So, the development of urethra, further development of mesonephric duct in males will be dealt in the class on male genital system. For the time being, you can understand that because of the ascent of the kidney, the orifices of ureter are moving cranially, and the mesonephric duct, you can see from these two pictures, mesonephric duct is moving closer to each other, and they are entering this part of the urethra. This is going to become the future prostatic urethra, and this mesonephric duct is going to become the ejaculatory duct. So, as you can see from this picture, because of the absorption of mesonephric duct, there is a triangular area formed on the posterior wall of the bladder. This is called trigone of the bladder. This is because of the absorption of the mesonephric ducts. As you remember, having seen the earlier slides, that mesonephric duct is from the intermediate mesoderm. So, trigone of the bladder is mesodermal in origin. I have already mentioned about the development of bladder. It is from the cranial part of the vesico-urethral canal. It is endodermal in origin. Later, what happens? The epithelial lining in the region of trigone is going to be replaced by the epithelium derived from the endoderm of the vesico-urethral canal. Please understand, trigone is formed by the absorption of the mesonephric ducts. Hence, it is mesodermal in origin, while rest of the bladder is coming from vesico-urethral canal, from which is a subdivision, one of the subdivisions of the cloaca, and hence it is endodermal in origin. This is a picture to show the trigone of the bladder in adults. This is the urinary bladder. Coronal section has been done. You can see the interior of the bladder. The lower part of the posterior wall, you see a triangular area. This is called trigone of the bladder. The posterolateral corners, you can see the ureteric orifice. This is the internal urethral orifice, and this is the female urethra. So, this triangular area is trigone of the bladder, the development of which has been dealt with in the previous slides. So, to summarize, the epithelium of the bladder is from cranial part of vesico-urethral canal. So, it is endodermal in origin. Other layers in the wall in the region of trigone is because of absorption of mesonephric ducts. It is from the mesoderm. Which mesoderm? It is intermediate mesoderm, which is a component of the intraembryonic mesoderm. Other layers of the wall elsewhere will be from the splanchnopluric layer of lateral plate mesoderm. As I had mentioned earlier, that splanchnopluric layer of intraembryonic mesoderm is in close contact with the endoderm, which gives rise to other layers of the wall. Only the epithelium is derived from the endoderm. Epithelium of the bladder is developed from the endoderm. Other layers of the wall elsewhere is from the splanchnopluric mesoderm. Having said this, we have already mentioned that the bladder is continuous with the allantois. So, this gets obliterated and is converted into a fibrous cord which is called as urachus. In adults, it is seen running from the apex of the bladder to the umbilicus. This is called as median umbilical ligament in the adults. This is a look at the interior of the anterior abdominal wall. This is the posterior surface of the bladder. You can see the vast difference: seminal vesicle, the posterior surface of the prostate gland, posterior surface of the urinary bladder. Here is the apex of the bladder. You can see a ligament extending in the adults to the umbilicus, that is called as median umbilical ligament, which is derived from the urachus, which is a fibrous cord, which is the obliteration of allantois. So, having completed the development of kidney, ureter and bladder, we will look at some of the congenital anomalies of the urinary system, that is kidney, ureter and bladder, which is the third objective of our class. So, to mention some of the anomalies of the kidney, first is renal agenesis. One or both kidneys can be absent. There can be hypo or hyperplasia of the kidney, that is, it can be underdeveloped, it is called hypoplasia. Overdeveloped, it is called hyperplasia. Sometimes there can be duplication of the kidney. There can be extra kidney on one side. Next is coming to the anomalies of shape of the kidney. Two things deserve mention. One is called horseshoe kidney. The other one is pancake kidney. We look at the details of these two conditions. First is horseshoe kidney. As I mentioned earlier, the kidneys are developed in the pelvic region and they are going to ascend up. When they ascend up, they are going to pass through an arterial fork formed by the umbilical arteries. In this process, sometimes you can see in this picture that the inferior poles are fused. Inferior poles are fused to form the horseshoe kidney. Please note, this inferior poles are fused and this portion is called isthmus. This is called as isthmus. So, what you are seeing here is inferior poles are fused and this is the isthmus. This is the abdominal aorta and you can see the origin of inferior mesenteric artery, that is usually at the level of L3 vertebra. So, this position of the horseshoe kidney, if you look at it, it's usually at the level of lower lumbar vertebra. As further ascent of this fused portion is prevented by the fused portion and the entire kidney is prevented by the root of inferior mesenteric artery. So, the kidney cannot ascend up. So, it is usually at the level of lower lumbar vertebra. You can see the ureters arising from the anterior surface of the kidney. They pass ventral to the isthmus. Usually, they pass ventral to the isthmus. So, this is horseshoe kidney, where inferior poles of the kidney are fused together. Next condition is pancake kidney. If you look at this picture, the two kidneys are fused, not the inferior poles, but the whole kidney is fused to form one huge mass. It can lie either in the midline or to one side, right side or left side. Then it is called pancake. It's an entire kidney which is fused. This is called as pancake kidney. Next, coming to the anomalies of position of the kidney, it's called migration defects. One is the pelvic kidney. I already mentioned that kidneys develop in the pelvic region. They ascend up to the lumbar region. If it doesn't ascend up, it is called as lies in the pelvis. You can see that the right kidney is in the pelvis, whereas the left kidney has ascended normally to its lumbar position. If it is going to lie in the pelvis, then it is called as pelvic kidney. It lies near the common iliac arteries. This is called pelvic kidney. Look at the picture on the right side. This clinical condition is called crossed ectopia. This congenital anomaly is called crossed ectopia. What happens is both kidneys are on the same side. And you can see the ureters crossing. So, it is crossed ectopia and this is the ectopic position of the right kidney. It has to ascend up, go to the right lumbar region. Instead, it has gone to the left side, lying below the normally ascended left kidney. And in this process, the ureters are crossing. It's called crossed ectopia. Next, I told you that kidneys, when they ascend, the hilum which is directed anteriorly rotates and hilum will face medially. Suppose there is no rotation, it's called non-rotation. Hilum will face anteriorly or forwards. Suppose there is incomplete rotation, it's not completely rotated to the medial aspect. Hilum will be directed anteromedially. This left kidney is normal, rotation has occurred. See the picture on what I am pointing out. There is reverse rotation. Hilum is directed anterolaterally. So, there can be anomalies associated with the rotation of the kidney. These three are rotation anomalies. Next is a clinical condition which is called as congenital polycystic kidney, where you can see lot of cysts within the kidney. We have already learnt that the excretory tubules of the metanephros should contact the collecting tubules. The ureteric bud comes in contact with the metanephric blastema, induces the metanephric blastema to form the nephrons which connect with the collecting tubules, which is derived from the ureteric bud. Suppose the excretory tubules of metanephros do not establish contact with the collecting tubules, what happens is there is cyst formation within the kidney. It's called as congenital polycystic kidney. This picture shows the congenital polycystic kidney. Coming to the developmental anomalies of ureter. Ureter is coming from the bud, which is called ureteric bud. Look at the picture which I am pointing. Suppose instead of one bud, there are two buds, duplicated ureteric bud. So what happens is there are two ureters, double ureter, duplicated ureters. See the picture which I am pointing, the third picture. Instead of two buds, there is a single stem and there are two buds coming from that. So what happens is, see the fourth picture, there is a single ureter but above it is branch. This is called as branching of the ureteric bud. So the ureter is branched, but the stem is of the ureteric bud is a single stem, and hence when it opens, it is a single ureter which is opening into the bladder. So this is duplication of the ureter. Look at this picture, this is complete double ureter. This is partial double ureter, as I have mentioned in the previous slide. Only thing with the complete double ureter is that the normal ureter opens into the bladder. The other ureter, which is abnormal, ectopic ureter, we mentioned it as ectopic ureter because it can open into different sites. The possible sites of ectopic uretral opening, or it can open in case of females into vagina, urethra, or into the vestibule. Here you can see it is opening into the urethra. This is female urethra. In case of males, it can open either into the urethra, or it can open into the ductus deferens, or it can open into epididymis. Then it is called as ectopic uretral openings. Uretral openings. It can occur at ectopic sites. So these are the anomalies of the ureter. There are two more conditions concerned with the development of bladder. Sometimes bladder can be in the form of a hourglass. It's called hourglass bladder. Sometimes it is divided into an upper and lower compartment if there is going to be a constriction in the middle. This is called hourglass bladder. There is one more clinical condition or a congenital anomaly which is called ectopia vesicae. In this condition, what happens is the lower part of the anterior abdominal wall and ventral wall of the bladder is absent. So the cavity of the bladder is exposed to the surface of the body. The cavity of the bladder is exposed to the surface of the body. So this condition is called as ectopia vesicae. This is because of the ventral body wall failing to close in the region of the lower abdominal wall and pelvic region. This is called ectopia vesicae. Next is the persistence of urachus. As we have mentioned that intraembryonic portion of allantois should get obliterated to form a fibrous cord which is called as urachus, which should extend from the apex of the bladder to the umbilicus. Suppose the lumen of the intraembryonic portion of allantois persists, you have an anomaly called as urachal fistula. You can see a fistula, urachal fistula. So, this is connecting the bladder to the apex of the bladder to the umbilicus. So, urine drains from the umbilicus. Differentiate this condition from the urachal sinus. In this third picture, C or the C picture, you can see that the lumen is persisting only in the upper part. The lower part is obliterated. So, this is urachal sinus. Lumen is not continuous with the bladder. In fistula, it is continuous with the bladder, there is urine discharge. But in case of sinus, it is not continuous with the bladder. So, that differentiates urachal fistula from urachal sinus. The picture in the middle, B, the picture B shows a cyst in the middle. Only a local area of allantois persists. And there is going to be secretory activity in it from the lining, and hence there is a cyst formation. This is called as urachal cyst. You can see the cyst here. It's because only the local area of allantois is persisting. Rest of it is obliterated. That is close to the bladder and to the umbilicus. That part of the urachus is obliterated. We call in adult as the median umbilical ligament, and this is a cyst, urachal cyst. So, these are the anomalies associated with the persistence of urachus. It has to be obliterated. In adults, it is called as median umbilical ligament. Coming to this case study, having completed all the clinical anatomy or the anomalies, congenital anomalies of the kidney, ureter and bladder, we will go back to the case which we have showed initially and understand the case. So, this we said it is a 45-year-old female who came with fever and loin pain, and there was a lower midline mass on the left side which was extending cranially to the umbilicus across the midline onto the opposite side. A CT abdomen revealed the diagnosis that it's a left pelvic. It's not a normal kidney, but there was hydronephrosis. The kidney was dilated, huge, and from left side it has extended cranially, crossing the umbilicus to the opposite side. And there was gross thinning out of the renal parenchyma. The hydronephrosis was secondary to the obstruction which was present at the junction of pelvis with the ureter. And since the kidney was not functioning, the left kidney, which was hydronephrotic, was non-functioning kidney, hence a nephrectomy, that is removal of the huge mass was done. So, the cause of this is that it's a pelvic kidney on the left side, right side kidney has ascended up to its normal position. So, it's called pelvic kidney. We have already talked in detail about this. It is mainly because of the failure of ascent of the kidney, which usually develops in the pelvic region. It has to ascend up to the lumbar region. If it fails to ascend during development, then it is called as pelvic kidney, and usually they will remain close to the common iliac artery. So, this clinical condition is left pelvic kidney, and this has been correlated with the development of the urinary system. So, we will summarize what we have learned in the development of urinary system. The class has focused on the development of kidney, ureter and bladder. So, we talked about three overlapping renal systems: pronephros, mesonephros and metanephros. And in humans, metanephros, which develops in the 5th week, was the one which formed the permanent kidney. That is the excretory units of the kidney: Bowman's capsule, PCT, Henle's loop and DCT. Then we talked about the ureteric bud, which is nothing but a mesonephric diverticulum which came in contact with the metanephros or the metanephric blastema, induced it to form the nephrons. So, the ureteric bud gave rise to the collecting system, that is collecting tubules, the ducts, calyces, pelvis of the ureter and the ureter. So, there are two sources of development. One is the metanephros and another is the ureteric bud. As has been mentioned earlier, kidneys develop in the pelvic region, then they ascend up to the lumbar region, and when they ascend, the hilum which was facing anteriorly will rotate and the hilum will face medially in adults. That is called rotation of the kidney. Then we talked about the development of the urinary bladder, which develops from the cranial part of the vesico-urethral canal, which is a subdivision of the primitive urogenital sinus, which itself is a subdivision of the cloaca. The ventral part of the cloaca is the primitive urogenital sinus. And the primitive urogenital sinus gets subdivided into a cranial part which is called as a vesico-urethral canal and a caudal part which is called as definitive urogenital sinus. As you can see from this picture, the mesonephric duct is opening initially into the cloaca, then into the primitive urogenital sinus, and later on it opens into the vesico-urethral canal. So, this part of the mesonephric duct gets absorbed into the bladder, and this is going to give rise to the trigone of the bladder. Since mesonephric duct is mesodermal in origin, trigone of the bladder, which is formed in its posterior wall by absorption of the mesonephric ducts, is mesodermal in origin, while the bladder which develops from the vesico-urethral canal is endodermal in origin. So, we also talked about various congenital anomalies of urinary system. One was the horseshoe kidney, where the inferior poles of the kidney fused with each other. If whole kidney fuses, the entire kidney fuses, then it is called pancake kidney, which can lie in the midline or to the right or to the left side. If the excretory tubules fail to establish contact with the collecting part of the kidney, it is called congenital polycystic kidney. It leads to the formation of cysts within the kidney. Sometimes the kidney itself fails to develop, it is called as renal agenesis. There can be problem with the ureteric bud, which is a mesonephric diverticulum, or it is a diverticulum or a bud from the mesonephric duct, can be bifid in some cases. It is a congenital anomaly which is called duplication of ureter or double ureter. And we talked in detail about the urachus, which is nothing but obliterated allantois. The allantois is continuous with the vesico-urethral canal. Later on it gets obliterated. You can see it is a content of the umbilical cord in case of fetus. So, allantois gets obliterated to form the urachus, which extends from the apex of the bladder, as I am pointing out, to the umbilicus. This is the future umbilical region of the embryo. This in adults we called it as the median umbilical ligament. Sometimes the urachus can persist, parts of it can persist, or entire thing persists, we call it as urachal fistula. Part of it persists, we call it as urachal sinus, or there can be a cyst formation in the urachus. So, this summarizes the development of urinary system. This class we have focused on kidney, ureter and urinary bladder. Having learnt the development of kidney, ureter and bladder, we will do assessment of what we have learnt by MCQs. So, first question is, following parts of the kidney develop from the metanephric blastema or metanephrogenic cap, except. The choices are A. Bowman's capsule, B. Proximal convoluted tubule, C. Loop of Henle, D. Collecting tubule. The answer is D. Collecting tubule. Reason being A, B and C are developed from the metanephric blastema, metanephros, whereas collecting tubule is going to be developed from the ureteric bud. We will move to the next question. All the following are true about horseshoe kidney, except inferior poles of the kidney fuse with each other, lies at the level of lower lumbar vertebra, normal ascent of fused kidney is prevented because of origin of superior mesenteric artery, usually produces no symptoms. The answer is C. The reason being the normal ascent of fused kidney is prevented because of origin of inferior mesenteric artery. As we have already studied, the horseshoe kidney, the lower poles are fused with each other. This is true. It usually lies at the level of lower lumbar vertebra because the ascent is prevented by origin of inferior mesenteric artery, because inferior mesenteric artery arises at the level of L3 vertebra. Usually horseshoe kidneys do not produce symptoms. So the answer for this MCQ is C. Normal ascent of fused kidney is prevented because of origin of superior mesenteric artery is not correct. Answer is normal ascent of fused kidney is prevented because of origin of inferior mesenteric artery. We will move to the next MCQ. One of the following develops from the ureteric bud: Bowman's capsule, proximal convoluted tubule, loop of Henle, calyces of kidney. The answer is D. Calyces of kidney. As we have mentioned earlier, ureteric bud gives rise to the collecting tubule, major and minor calyces, pelvis of the ureter and the ureter. So answer is calyces of kidney. We will move to the next question. Trigone of the bladder develops from, we said, the triangular area on the posterior wall of the bladder, trigone of the bladder. It develops from A. Absorbed mesonephric ducts, B. Metanephros, C. Pelvic part of urogenital sinus and D is phallic part of urogenital sinus. We have already understood that trigone is going to be developed from the absorption of mesonephric ducts into the vesico-urethral canal. We will move to the next question. One of the following is true about urachus. The choices are: it's an obliterated allantois, it's an obliterated vitelline duct, it's not a content of umbilical cord, it is attached to the base of the urinary bladder. The answer is A. It's an obliterated allantois. We have mentioned earlier that allantois gets obliterated to form a fibrous cord which is called as urachus, which will extend from the, not from the base but from the apex of the bladder to the umbilicus, and it becomes a content of the umbilical cord. So the answer is it's an obliterated allantois. Obliterated vitelline duct is called as Meckel's diverticulum. So answer for this MCQ is it's an obliterated allantois. Thank you all.